Rafe Bernier. I'm a professor in the Department of Psychiatry at the University of Washington. I'm also the director here at the Seattle Children's Autism Center. And I'm here with Rachel Earl, who is a doctoral student in the Department of Educational Psychology, who works in my lab. And today we are going to do an abbreviated discussion of evidence-based practices focusing on autism. And I think what we'll do, just given our abbreviated time frame, is we are going to touch base about just kind of a mile-high overview about what autism is when we're talking about autism today, and we're going to just touch for about a second on what's best practice in the diagnostic process, and then we're going to move in and to really spend kind of the lion's share of our time here about interventions in autism. With the knowledge that Rachel and I are both very approachable, and we are happy to be contacted if anyone has any questions about any of the things we're going to discuss. So without further ado, I'm going to jump right in and just start just by saying we have nothing to disclose. All the funding comes from National Institutes for Health, Autism Seekers Simons Foundation. So no conflicts of interest. I kind of mentioned what we'll be talking about today. Just touch base on autism and really think about evidence-based practices, primarily around interventions and a little bit about diagnosis. So just briefly to start, what do we know about autism? Well, we know autism is a neurobiological disorder. That is, it's a disorder that's based in the brain, and it's characterized by impairments in both social communication and interaction, as well as the presence of restricted and repetitive interests and behaviors. It's a behaviorally defined disorder. So that is where the diagnosis is made simply based on the observation of the presence or absence of behaviors in these two different domains. What else do we know about autism? We know that autism is diagnosed 3 to 4 times more often than it is diagnosed in girls. We know that it is found in all social class levels and in all racial ethnic groups. Autism does not discriminate. We do know that autism is a highly genetic disorder, although as of today, there are no genetic or biological tests that are used to diagnose autism. As I mentioned, it's diagnosed simply based on the observation of behaviors. We also know that there are very effective treatments at improving outcomes for individuals with autism that are behaviorally based. And importantly, we know that most interventions are associated with improvements for some children, but no interventions show improvements for all children with autism. So that is the quick mile-high overview that we're just zooming right through here today, because we want to talk a little bit about what the evidence tells us about interventions in autism. I want to spend one moment first talking about the diagnostic process, though, and a little bit about the evidence-based approaches to making a diagnosis of autism. So there are a number of different components to a diagnostic evaluation. The first piece is that we really have to have a very good medical, developmental, and symptom domain history. This is usually obtained through a clinical interview with a caregiver in a highly standardized or structured interview that's been developed. It's called the Autism Diagnostic Interview. There's a revised version out now. It's called the ADIR. Now, this would be part of the gold standard diagnostic process of autism, the use of this standardized instrument. However, it's not frequently used in clinical settings because it requires a great deal of training to develop and achieve reliability with, and it's also quite a lengthy interview. So while this is certainly used in research settings, it's not often used in clinical settings, and it's been replaced often by just a clinical interview with a caregiver who's focusing on, again, good history taking as well as understanding symptoms in those two domains of autism, social communication and interaction, and repetitive interests and behaviors. The other key piece is going to be observation of social communication and interaction, looking at play skills, and then looking for the presence of atypical behaviors. And again, the gold standard instrument used in this case is the Autism Diagnostic Observation Schedule. And there's a second version, a second edition out that's out now. So the sort of best case scenario, I would say, would be the combination of the ADIR and the Ed.S, the two of those instruments combined. Again, it's not often used in a clinical setting in combination just because of time interest and being able to meet the demands of all the patients that require diagnosis. But the Ed.S is, again, a standardized instrument, a tool that is very helpful in providing some structure to the way we're observing behaviors. There's a number of other ways you could do that. That could be done through observation of parent-child interaction. It could just be simply by the observation of the child in a exam room while just doing your medical and developmental history. There's a number of ways to get those observational skills, the observational opportunities out, and the ADOS provides a very clear gold standard approach to doing that in a semi-structured way. Other different types of testing that really becomes helpful for the diagnostic process is going to be cognitive and adaptive assessment. Cognitive testing is a key component if you're thinking about a differential diagnosis that regarding intellectual disability and autism. Many of the behaviors that we see in autism, we can also see in individuals with intellectual disability, and so we need to be able to tease that apart. And cognitive testing can help inform that process. Other types of testing that are involved in the diagnostic process would be genetic testing, a neurological exam, if needed. Genetic testing, I'll just highlight that it's recommended by the American Academy of Pediatrics that anyone receiving an autism diagnosis should get genetic testing. Neurological assessment, of course, is very helpful if there are additional comorbid issues or questions about seizure activity, which is a highly comorbid condition in autism. Additionally, there are many other types of specialty assessments that can be very helpful for an individual with autism. We know that sleep dysfunction is highly comorbid in autism, as well as gastrointestinal disturbances. So getting that specialty assessment from one of those providers can also help out, just inform and flesh out your understanding of what's happening in autism. Now, who is able to diagnose autism in terms of being recognized at the state level or at the insurance level varies state by state. In Washington state, the providers that are able to provide a diagnosis of autism include psychologists, developmental pediatricians, psychiatrists, or neurologists, or specifically here, advanced registered nurse practitioners who are employed at a center of excellence. That's a terminology determined by the state here in Washington state. ARNPs are able to also confer an autism diagnosis. Around the country, there are other providers that have expertise in this process. So, for example, in other states, speech-language pathologists sort of have diagnostic power as seen by the state or insurance companies in that state. Here in Washington state, it's just providers we mentioned. So one of the challenges, of course, is that demand for diagnosis is much higher than what's available in terms of the provider expertise availability. And so a lot of centers really around the country are struggling to figure out what are appropriate ways to speed up the diagnostic process. How do we increase provider capacity through training? But it's still leaves a lot of wait lists, very long wait lists at centers throughout the country. So what I'm going to do now, with that note, I'm going to switch gears a little bit, and we're going to pass on the baton to Rachel, who's going to talk a little bit more about evidence-based practices regarding interventions in autism. I'm going to just jump ahead here a couple slides where just about those are specifically about some of the diagnostic process. And we're going to chat a little about intervention now. Great. Thanks, Rachel.
All right, wonderful. All right. So we are going to be switching gears to chatting a little bit about interventions. And when we think about interventions for ASD on the whole, there's several kind of key defining features. So first of all, the aim is to improve skills in core deficit areas, including social communication, and then those restricted and repetitive behaviors. Given that in autism, adaptive functioning is often impaired in individuals with ASD, intervention is also focused on optimizing functional outcomes, so increasing independence, acceptance of symptoms, whether that be from the client or the family, as well as increasing productivity, whether that be in daily living skills, academic endeavors, work endeavors when an individual reaches adulthood. ASD is considered a lifelong diagnosis, and as such, treatment needs are expected to be ongoing and to adjust and evolve as new phases of development occur. And this can really be a financially taxing and daunting reality for families, as lifetime costs are estimated to be about $3.5 to $5 million for a family to participate in treatment across the lifespan. And as individuals with ASD are being diagnosed at an increasingly earlier age due to the specificity of our diagnostic assessments and really understanding what ASD is, it's now recommended that affected individuals really begin treatment as soon as possible so that intervention can be focused on early development. Because research shows really strong evidence that targeting social and communication skills early on in development is really optimal for progress. So you might ask, kind of what constitutes an intervention for ASD? What types of interventions are out there? Well, this is just a sample of a few types of treatments that claim benefits for this population. And as you can imagine, this overwhelming number of options really causes many families and their referring providers to feel pretty confused as to where to start for treatment, particularly since, as Rafe mentioned, there's really no one intervention that works for all individuals with autism. So I want to kind of break this list down by discussing what we consider evidence-based practices for autism first, then briefly touching on not so evidence-based practices, and how to kind of parse these apart as a provider and help guide families toward the treatment that makes the most sense for them. All right, and so differences between ASD treatments, they vary on a variety of different things. So they may vary on their scope. Some interventions are very skill-focused, whereas others are comprehensive and addressing multiple realms of development. Others vary in their targeted outcomes. Speech therapy is very focused on language and communication for individuals with ASD, whereas participants in occupational therapy would be focusing on daily living skills and sensory impairments. Behavioral interventions are going to target behaviors, challenging behaviors, or kind of increasing compliant behaviors. Setting may vary, the intensity. Some interventions are only provided for an hour a week, whereas some are provided for 40 hours a week. They also may vary in their duration and the recipient, whether the client is kind of the child is the target client or caregivers are the focus. And then ASD treatments really do vary in their methodology as well. And as I'm going to talk a little bit more in the next slide. So kind of the two primary camps for ASD treatments are behavioral interventions and interventions that come from a developmental focus and lens. And over time, these have really evolved into two separate silos, two separate camps, with behavioral interventions being far more adult-directed and scaffolded, and developmental interventions being more child-focused and an increase in focus on attachment and affect and social interaction. And over time, there became to be kind of a conflict between the two, each considering themselves to be the recommended treatment for ASD. And so we really are kind of looking at a case of kind of Dr. Seuss's classic Sneetches issue, where we have, and if you guys may recall, there was the star belly Sneetches and the Sneetches with no stars upon theirs, and both had kind of the opinion that they were the best, when actually they were more similar than different. And so once they realized this, they began to coexist and could be friends. And the same thing has happened to our behavioral and developmental camps in the creation of this kind of balanced, more naturalistic approach that's really incorporating elements from both approaches. And so we can see that by coexisting, we have the opportunity for participants and clients with ASD to have a more holistic treatment. I'm going to briefly touch on applied behavior analysis, which is really the foundation of many comprehensive behavioral treatments for autism. It has a strong evidence base for addressing these core deficits of ASD. And when it comes to ABA, really broken down in a very, very brief and cursory state, is that the core tenet of ABA is understanding behavior in the context of function and environment, both desirable and undesirable behaviors. So our antecedents are the events that elicit the behavior. In teaching a desired behavior, it's providing a prompt or a cue, and the consequence is what follows the behavior, whether that be positive or negative. And when teaching, consequence should be a reward or a motivator, something that keeps the behavior continuing. Early intensive behavioral intervention, as we mentioned, is really considered to be critical for individuals with ASD. And EIBI really draws from ABA principles specifically. However, ABA is really appropriate for a really wide age range. It's just particularly emphasized in early childhood, but can be used across the lifespan. And so I want to touch on a couple quick comprehensive models of ABA, all of which have a strong evidence base. The first being discrete trial training. And this is a type of ABA where a skill is broken up into smaller parts. You teach one sub-skill at a time. It's very scaffolded and often thought to be kind of more a therapist and a client sitting at a desk doing kind of trial upon trial. And prompt fading and shaping of appropriate behaviors are used until the behavior that is desired is mastered, so kind of slow approximations of the behavior that's wanted. And then rigorous data collection follows with discrete trial training to really track behavior over time. Then we have the Early Start Denver model, which really focuses on developmentally appropriate skill learning with a particular focus on a child's affect, their social attention, their arousal in social circumstances, and provides a more kind of naturalistic kind of focus on relational aspects that are impaired in ASD. It also contains rigorous data collection to monitor that behavioral progress over time. And then there's pivotal response training, which focuses on two pivotal behaviors, motivation and then responsivity to multiple cues. So the ability to be motivated to elicit a desirable behavior and then to be able to elicit that desirable behavior in a variety of different situations or antecedents, as we spoke about before. And the thinking is that by changing these behaviors, everything else will improve. So the skills that are acquired are then going to be able to extend out to different, generalize to different settings and different circumstances. And just as the other two I mentioned, data collection is a huge part of PRT. And so we can see here that each of these three approaches have differences, and they have some differences in their approaches and how much they lean on more heavily behavioral principles and heavily developmental. However, they all have a strong evidence base, and they all utilize this core ABA component and gather data to track progress of learning over time. So as we mentioned before, this early intensive behavioral intervention is really thought to be a very important tool when we think about treatment for ASD, and has over time begun to combine behavioral and developmental perspectives. And the research that's been done on early intervention has really focused, say, what are the key ingredients? How do we think about this in a way that's most successful? And research has shown that EIBI, that is a comprehensive curriculum that's addressing multiple different domains of development, including attention, imitation, language, play, social interaction, is very useful. Successful EIBIs are also sensitive to normal developmental sequence. So that's where we think about that developmental approach and what is really developmentally appropriate for this child at this time. The supportive teaching strategies are highly, highly supportive. So based on ABA, core components, and scaffolded learning. Behavioral strategies are often included in early intervention to target disruptive behaviors and improve compliance, as well as parental involvement is shown to really augment outcomes. Then we also see a gradual, careful transition from a highly supportive scaffolded learning environment to more naturalistic environment. So really understanding how does a child generalize to the skills they've learned in therapy to a variety of different interactions and communication opportunities that they're having outside of therapy. At this point, research shows that about 25 hours per week is recommended, if not more, for at least 2 years. And the onset of intervention really is optimal occurring between 2 to 4 years of age. However, there is a wide variation in when kids enter into early intervention. So some enter younger, closer to 18 months of age, and some are entering at 5 or 6, depending on diagnosis and family factors. I want to touch on the TEACH model, which is coming out of the University of North Carolina, started in 1966 by Eric Schofler. And this particular model has an aim to support children in their natural environments and set them up for success. So it's actually using strategies like physical modification of space, providing visual cues, schedules, and structuring an individual with ASD's environment so that you can really accommodate their needs. And it's really considered to be more of a framework than a targeted intervention per se. It's kind of a framework that can be applied to a variety of environments. And as such, it really serves a wide age range of individuals, starting from early childhood all the way up to adulthood. Social skills training is something that is used frequently with individuals that have intact cognitive and language abilities, considered an evidence-based practice with a growing number of randomized control trials that are being published on social skills curriculums. However, one thing that continues to be an issue is generalization of the skills from the therapy setting to a child's regular peer environment, as well as when doing group design studies. Individuals with ASD are going to respond to the training differently. And so when looking at group effects, that can sometimes be problematic or not tell the whole story of what treatment is effective for whom. Social skills trainings can occur in multiple settings. They can occur in the clinic, home, school. and take on multiple formats. So either it's a dyad where an individual with autism is working with a typically developing peer or another peer with autism on these skills, or it's in a group setting where it's more therapist-led. Therapist-led intervention approaches are common, as well as bringing in a series of typically developing peers that can provide that practice and generalization for a child with ASD. And there's a wide variety of different types of social skills curricula out there. One of the evidence-based curricula coming out of UCLA is called the PEERS program. And kind of each of these different social skills trainings that do seem to have a strong evidence base have some kind of key components. So they have the role of either the therapist or a trained peer is to really provide a concrete understanding around a social skill, and then to provide concrete reinforcement for the attempts of practice that an individual with ASD is practicing, utilizing these skills, and then highlighting the natural contingencies that occur in social interaction. And often these social skills trainings combine learning these very concrete skills with fun activities that really elicit natural social interaction for individuals on the spectrum, developing rules that are clear, concrete, and appropriate. So really spelling things out. Because individuals with ASD have deficits in social interaction, the skills that we sometimes think of as intuitive in social interaction are not intuitive for this population. So really breaking things down so that they're concrete and easy to understand. And different activities that allow this kind of learning to occur in a fun way are things like conversation ping pong, where in teaching a back and forth conversation, you might incorporate into a ping pong game and teach how kind of that back and forth is just like the way the ping pong ball, goes from one end of the table to the other. Emotional charades is another one that is frequently used in social skills training. Social stories are an EBP that are very flexible and a really great tool for use in both clinical and educational settings. What they do is they really provide a structured teaching opportunity to help individuals with ASD anticipate challenging situations and then learn explicit ways to respond to those situations. And so as we can see here, this is a social story about recess. And there's a couple key components I want to highlight that make this a social story and make it useful for an individual with ASD. So first of all, it provides concrete context to, okay, this is recess. What happens at recess? What do children do at recess? To really break it down so that a child knows what kind of the environment with which he might be expected to do something. A social expectation is introduced. In this case, it's everyone should play safely, and when the whistle blows, that means it's time to line up and go inside. And then it provides an individual instruction and a consequence for that behavior. So I'll try to line up as soon as the whistle blows. This will make my teachers happy. After I line up, I'll try to stay in line and everyone will be proud of me. So it really spells things out in a very concrete way, but can stay very flexible to whatever challenging situation has emerged for a child on the spectrum. So in this way, they can really be adapted to individual needs and treatment goals. What's great about social stories is there's resources for creating them online as well. I'm going to briefly touch on pharmacological treatments, and research has shown that pharmacological treatments are used with populations with ASD. Antipsychotics such as risperidone are used to treat aggressive behaviors. SSRIs are used to treat symptoms of anxiety, depression, obsessive compulsive disorder, as well as aggressive behaviors as well. Naltrexone and stimulants are used to address hyperactivity, inattention, and then mood stabilizers are used to address mood lability in this population. And it's important to note that all of these different pharmacological interventions are used to treat common comorbid issues to ASD, not autism itself. So at this point, there's no medication that is specifically addressing the core impairments of autism. Now, in the future, as we understand the genetics of ASD and we start to really understand what's going on at the cellular level, it may be possible for us to understand and create pharmacological interventions that are really addressing the ASD phenotype as well as medical complications. So that is a hope for the future, but at this point, pharmacological interventions are really focused on addressing comorbid disorders. So I'm going to briefly touch on the not so evidence-based practices that are out there, which are kind of summarized as these complementary and alternative medicines and treatments, or CATs as I'll call them. And really CATs are anything that falls outside the realm of mainstream medicine and often doesn't really have a very strong scientific research base behind them. And as you can see, it's a really wide range of types of interventions that are used, particularly for this population. And so in light of the fact that we don't have a lot of research on these different interventions, it's interesting that individuals and families on the spectrum often seek out these CATs, which prompts the question, kind of what's going into that? Why is that occurring? And so far, the research that's been done shows that there's limitations to conventional approaches for families that really prompt them to turn to alternative treatments for ASD. First of all, it's expensive. Conventional approaches can cost up to $30,000 a year, and outside of Washington, many states don't cover ABA insurance, and so that's a huge expense that families incur. The effort, the amount of time it takes to do these treatments is taxing for families. Side effects to medications can create more problems than were there before, as well as there's just an added risk for medical and psychiatric complications, which can make families nervous and uncomfortable. And then also some individuals, as we mentioned, are not responsive to the conventional approaches for ASD. No intervention works for all children. So there are going to be clients and their families that feel that the conventional approaches haven't been working. And so this might all prompt families to seek out these kind of treatments that don't have a strong evidence base and really vary in how safe they are and how effective they are. We see that the average child with ASD participates in about 5 to 7 treatments. Sometimes all at the same time, which is something that is concerning in some ways, because when multiple treatments are being used, it's really hard to track what intervention is actually effective or what treatments might be interacting in a way that doesn't really show gain. A wide range of families that have a child with ASD, individuals with ASD, use a CAT. Again, it varies widely depending on the study. But interestingly, there have been studies comparing individuals with chronic medical impairments outside of ASD to families with ASD. And when comparing those two groups, we see that individuals with families with ASD are not more likely to seek out alternative treatments than families that have a chronic health impairment, but they are more likely to seek out treatments that are not safe, disproven, or invasive compared to chronic or health impaired families, which is concerning and something that as we think about research moving forward, really understanding how these CATs impact a child's well-being and safety and making sure that information is disseminated to families appropriately. And as I mentioned before, there's very limited research on the efficacy of CATs at this time. The hope is that we understand more as time goes on. So I want to briefly touch on kind of what does the research tell us? And I want to touch on a few review studies that really provide a nice kind of bird's eye view of how we think about EBPs in autism. A review study in 2011 was conducted by Warren and colleagues, and it was a review of studies conducted between 2000 to 2010 for participants ages 12 and younger. And so a series of approximately 150 studies were looked at and evaluated for quality. And that quality was evaluated on kind of several key criteria, first of which being study design. Did the study employ a group design, and were the groups randomly assigned? Diagnostic process was included as an evaluative tool, how participants were ascertained and characterized, what the intervention entailed, dosage, duration, et cetera, as well as outcome measurements. So did the outcome measures demonstrate adequate reliability and validity, and were individuals coding behavior blind to intervention status? Statistic analysis was evaluated, as well as the applicability of the study, how outcome measures were, where they were sampled, whether they were measured in at least one context outside of the treatment setting, and whether they focused on generalization or an opportunity for follow-up to see whether participants had maintained gains over time. And what Warren and colleagues found was that out of 159 unique studies, only 13 fit the criteria for good quality studies. 56 had a fair quality status, and then 90 had a poor quality status. What they found was that medications like risperidone and aripiprazole improved challenging behaviors, but they had side effects that were notable, and that they did not address social communication impairments, as I mentioned earlier. Early intensive behavioral intervention kind of took the wide sweep for the amount of developmental skills that it addressed. It improved cognition, language skills, and adaptive behavior. Cognitive behavior therapy showed promise for addressing social communication impairments as well as challenging behaviors. Anxiety, depression are disorders that are, as well as obsessive compulsive disorder, are seen as comorbid with a portion of individuals with ASD, and CBT can be a very useful strategy for that. Across many of the good quality studies, parent training was included, and that really augmented the treatment outcomes that we're seeing. The TEACH model, as we referenced before, participants in that intervention showed improvements in cognition. And then we really found little empirical support for any other treatments. So that includes alternative treatments that were looked at. And so for the purposes of this study really did focus on highlighting studies that have a group design and that are kind of the formal randomized control trial. And so I want to briefly touch on another review study. Oh, I'm sorry, I was chatting without without putting for the slide. Okay, so with the review study in 2015, really kind of broadened the scope of studies that were being looked at. And so I want to touch on that because in the field of autism, a single case design is a frequently used study design to measure changes in behavior. And so by not including those single case designs in the 2011 study, it just didn't necessarily represent the full gamut of studies being looked at. And so in 2015, Dr. Wong and colleagues did a review of 456 articles. This was across a larger time span, 1990 to 2011, and looked basically at study designs that were either experimental, quasi-experimental, or single case design. And they actually excluded medication and alternative treatments for this particular study and just focused in on the behavioral and developmental interventions. And notably about this study is they widened the age range of participants that they were looking at. So they actually looked at interventions for children from birth all the way up to the age of 22. And as you can see on the figure on the right, that they present the ages of participants on the x-axis and the number of studies on the y-axis. And you can see that the majority of studies being done for individuals with autism are between the ages of 3 and 11. And as we get to the opposing ends of the developmental spectrum, we don't see as many studies being conducted. I think what's also interesting about this figure is we see that the proportion of studies that are single case design are far higher than group studies, indicating that we need to continue to bolster the number of group studies that are being conducted. And all right, and so particularly for this study, the criteria, they did evaluate single case designs, but single case designs there had to be more of them coming from multiple different research groups in order to be considered an evidence-based practice. So there was a higher threshold for number of studies conducted. And here's what they found. So they identified 27 evidence-based practices, and they actually evaluated them across 12 skill domains and matched interventions to skill deficits. So what was interesting about the study is they included things like kind of holistic manualized treatments like cognitive behavioral intervention, discrete trial training, pivotal response training. However, they also pulled out core elements of ABA and identified those as evidence-based practices, sort of in an effort to really understand what are the active ingredients and key components to behavioral interventions. And this is notable because research is really trying to understand how do we modularize interventions for ASD, how do we come up with the active ingredients and the core components that can then be individualized. And as you can see the graph on the right, we have the evidence-based practices on the left and then the various domains that each of those interventions address, which is helpful as we think about matching interventions to skill deficits and make sure we're individualizing treatment appropriately. All right, so I want to touch on what research tells us about early intervention. We've touched a little bit on kind of the successful early intervention behavior, early intensive behavioral intervention. What the research tells us is it's very effective for some, but not all children, and that children with higher IQs are really likely to respond better to treatment. We see that early intervention is effective, and it's effective at supporting children to really enter in and participate in a natural peer environment. So a substantial proportion of children are able to attend regular education classes. Gains are stable, so gains that are made early on in childhood are stable into adolescence. As well as early intervention really is cost effective, given we talked about the millions of dollars that are spent on intervention across the lifespan. The ability to target ASD impairments early is cost effective and reduces the amount of treatment that an individual may need later on. Support for both behavioral and developmental approaches are found in the literature. And as I mentioned before, really is kind of bringing together both of those approaches to find a common ground might be the most effective way to address ASD impairment. And research is really looking for the active ingredients. Is it dose? Is it age? Is it the agent of change? Who's administering the intervention? That really to better customize treatments to individual needs. All right, I see that it is 1:30 now. I'm going to we have just a couple slides left, and I'll just kind of power through these if people are able to stay. So thinking about kind of future directions for intervention, we have come a long way in the last several decades in understanding how to think about interventions for ASD, but we still have a long way to go. And it's really important that we find a balance between finding treatments that work for the entire diagnostic group. As of now, we have not found that, but also acknowledging that individual differences occur, and that's really important to adapt based on a child's individual presentation. And we know that individuals with autism present very differently and have a various degree of challenges that need to be addressed in therapy. Here's where we see kind of directions, research for interventions for ASD going in the future. We see anticipate an increase in parent-focused interventions where parents are really learning how to be the therapist for their child as well outside of a therapy session, so that the child's really getting this naturalistic support and scaffolding of the skills that they need to learn. We do anticipate an increased examination of alternative treatments, particularly given the number of individuals and families that are seeking out those treatments. We find that the more stressed individuals are, the more number of conventional treatments that are being used, it's actually more likely that a family is going to seek out an alternative treatment. And so we want to make sure that we're guiding families in what is the most safe and effective intervention, as well as making sure we're helping kind of coach them through that process of deciding what interventions to use. Anticipate the use of technology in intervention as we continue to learn more, particularly in how to support individuals with autism who have limited language ability. I think technology is going to be a huge support in that area, as well as interventions that are tied to the biological mechanisms of autism. We're understanding more and more about how specific genes function and disrupted proteins might play a role in the autism symptoms. And in the future, we can think about personalized medicine, where we're really adapting medication that might address specific biological pathways that could address symptoms and alleviate symptoms, as well as an increase in modularized approaches to treatment and treatment that is conducted in community settings, research that is conducted for that treatment, to make sure that we're really understanding the various different types of factors that go into how we individualize treatment and anticipate the needs of individuals with autism and their families. So lastly, I just want to leave you with a few questions as providers that may be seeing individuals with autism come through the door and looking for treatment and what makes the most sense for their family. Just some questions to think about as a provider regarding specific treatment. So first of all, I think a major question to ask is, will the treatment result in harm? Particularly if the family is thinking about consulting alternative treatments, really doing some research as to the safety of those treatments and figuring out when to tolerate and monitor progress, if it's a low risk of safety concerns, or if it's a treatment that really has indication that it might harm the safety of your client, helping avoid and discourage them from seeking that out. As well as asking if a treatment is developmentally appropriate. Especially with that developmental approach, we want to understand that we're really meeting a child at the developmental level that they need to be intervened at. So we want to make sure that it's developmentally appropriate and sensitive to the individual. Beware of interventions that say this will work for everyone, or that this will work for kids regardless of the developmental span. We really want to make sure that we're being individualized and targeted in that developmental lens. Asking how will failure of treatment affect the family. Families that are facing treatments for their child with autism are often confused and having difficulty really navigating this. It can be a very stressful and taxing experience. And so kind of consulting with families and helping support parents in their stress levels and helping support them to understand kind of in trying this treatment, what will be the impact. I think in general, what we try to do is recommend that families really try out treatments one at a time, rather than trying kind of throwing the whole kitchen sink in, which is a really common impulse, particularly following a diagnosis. But as I mentioned before, what's challenging when multiple treatments are going on at any given time is that we can't really tell which one's effective and which is not. So as providers can encourage families to try one at a time and monitor progress, that will, we think, will be helpful over time to help families really find the intervention that makes the most sense for their child. As we mentioned before, really understanding the scientific evidence behind these treatments. As more and more research is being published, we can really understand what treatments are effective and what are not. And then how will the treatment be integrated into a child's current program? So really, how does this make sense for a child's day, a family's life? How do we think about making treatment accessible and family friendly, as well as really something that then allows for the skills learning and therapy to be generalized out, generalized to a child's school environment, to their home environment, and aiding that kind of creating connection points between therapy and then the environments that are occurring outside of the therapy room to help with that generalization. All right, that was a whirlwind tour of evidence-based practices for ASD. Thank you for your time, and we are happy to answer questions. As Rafe mentioned earlier on, feel free to contact us, and we're happy to answer some more questions at a later time. Thank you very much.